Hello and welcome back. I'm your host, Michael Stamatinos with the Advancing Healthcare Innovation Show. And if you're new to us, man, we're just super excited to have you. You know why? Because we are having some just incredible conversations with real leaders that are painstakingly trying to change and impact the future of healthcare. And we're really passionate around access, innovation, adoption, leadership. And if you haven't tuned in before, make sure you hit the subscribe button now where you can get any of future episodes that come right into your inbox. And as part of our commitment to just kind of keeping you updated with the latest and greatest, I want to welcome our next guest. We're just incredibly excited to introduce this individual whose career exhibits just a passion for improvement and innovation, specifically within behavioral health. So Mark Bontrager serves as a crucial role within the Behavior Partnership Health Plan of California, where he's really wielding his expertise to manage partnership activities related to behavioral health services and community projects. So he's got just an unwavering dedication and commitment to improving access to mental health and substance use options. Mark works in alliance with leadership, member counties, providers, and even the community at large to shape the health plan's approach to these critical services. And he's a really interesting background. He combines his law background and a master's in social work to kind of create this unique harmony of law and empathy. And even outside of his current role, outside of his day job, Mark is really, really committed to making a difference. He's volunteered with organizations like the Napa County Workforce Investment Board and the Children's Justice Act Task Force. So these roles just sort of further highlight his commitment to helping his community. And we're just in for a really enlightening discussion. So Mark, it's great to have you here. Welcome to the show.
Well, thank you. Thank you for the introduction. I'm not sure I can relate to the idea that it is total harmony when it comes to my background, but I do my best every day.
Well, I mean, you get the blend of, background in law. And so you really understand rules and regulations. So maybe kind of let's dovetail into the transition from, practicing law to moving into social work. Can you maybe give us a little bit of a flavor of that story and
Sure.
what you're working on now?
Sure. Actually, it went the other way around. So I started in social work and was working with children and families impacted in the child welfare system. And I saw how the child welfare system impact the lives of individuals and children and youth impacted by it. So I decided to go back to law school and study law. And then I proceeded to practice law, particularly in the field of child welfare, adoption, and special education law for several years, and then found the opportunity to get more into administration and then ran a series of nonprofit community mental health clinics and a foster family agency. And then about 5 years ago, I moved over into managed care and healthcare.
Pretty awesome transition. So when you're thinking about, the things that you're focused on now and all the historical things that you worked on, do you see any of the guiding principles that you use within those other environments, and how have you sort of applied those into what you're focused on now?
Yeah, great question. I think the overarching takeaway I have, whether it's in clinical work in the field of mental health, or if it's working with individuals impacted in the child welfare system, or even patients in healthcare, I think the number one takeaway I have is that people want to be heard. And that is so essential and fundamental, regardless of venue and regardless of intervention, that people want to be heard and need to be heard.
So knowing that that's sort of the true north and the members that you currently serve, what are some of the mechanisms that you're deploying today to make sure that the members are heard? Can you maybe talk about some of the programs and things that you're working on?
Sure. I mean, I work in the Medicaid, or in California, we call it the Medi-Cal arena. And my specific position is that of behavioral health administrator. And so I ensure that we are doing our darndest to meet the access and services that behavioral health services related to the members in our 24 counties in Northern California, that they may have any needs that they may have, our services related to substance use treatment and/or mental health services, and trying to ensure ready access. And so one is access, to ensure that they have access, and that can be challenging,
Mm,
uh, not only in some of our more urban areas, but also in our rural areas. It can be very challenging because just a
mhm,
lack of providers and infrastructure associated with
mm.
some of those areas. There's really a structural inequity between more urban and suburban and then rural areas, inequities in services and service providers. So we try to take bites at that apple to look at telehealth and pretty significant recruitment incentives to kind of far
Mm.
afield places for providers, and try to engage and incentivize folks to participate in being a provider of services, particularly in more remote areas.
So for those remote areas,
Mhm.
what are some of the things that you've done to really try to attract the right type of clinical talent that wants to treat those types of patient populations? What's the dynamic and the relationships that you kind of have to forge to build out a robust network, and what have been some of the gaps and some of the challenges within that?
Yeah, lots of challenges. Like I was mentioning, we do have a provider incentive recruitment program. We spent well over $10 million thus far in trying to recruit providers to particular localities.
Mm,
That, combined with leaning in strongly into the adoption of telehealth, not just getting and contracting with telehealth providers, but also creating sites in more remote areas where they will host telehealth services, where there's adequate bandwidth and Wi-Fi, et cetera, because not all of our more rural areas are well positioned with some of those services. So we have to have host sites, and we pay for those as well as another mechanism. And then one recent
Wait,
thing.
hold on. So hold
Okay,
on.
go
So
ahead.
you're saying those sites are where patients go, or sites where clinicians are actually uh, seeing the mass majority of patients? It sounds like maybe it's more patients going in there and clinicians are there. So it's like system setup. Just want to make sure I understood that.
Yeah, good question. So we have a number of safety net health centers that service our
Right.
areas, and that's the predominant service delivery system, are these federally qualified health centers.
Hmm.
Uh, those centers serve not only as sites for primary care, but also host sites that we can bring in specialists via telehealth. And
Hmm.
those sites are, well positioned with bandwidth and Wi-Fi and things like that, so they can actually provide that host site for to
Hmm.
bring in a specialist or a necessary provider that that particular safety net health center may not have itself. So we try to both strengthen our existing safety net health centers, but also
Right.
bring specialists into those centers via telehealth as well.
And what have been some of the outcomes that you've seen as a result of that initiative so far? Any little wins that you want to sort of share?
Well, access is number one, and what we find is greater utilization. So our desire is that folks get preventative care, they get interventions early for
Yeah.
better outcomes. And
Mhm.
if you remove some of those hurdles and burdens of a 3 or 4 hour car ride to see a specialist, which means one can't necessarily go to work that day if they have to
Yeah.
take a half day off. So removing those burdens to access actually enhance utilization, and that's what we're trying to do.
And do you find just when you're working with this type of a patient population, what do you guys do to get into that into the shoes of the member, and to make sure that you're meeting them kind of where they are? Because I think that oftentimes it can be easy to say, well, it's just so easy, just get to this place and you get treated, and how do you sort of assess and evaluate the barriers? And obviously your background helps in that, but what are some of the other ways that you've been able to really try to meet the patient's members where they're at on their journey?
Yeah, that's a great question. So, we are required to do ongoing surveys of all of our members. We also have a pretty robust grievance tracking system. And so we look at that and try to identify if there are trends. And then we also do every year a population health needs assessment, where we look at the needs of every respective community that we serve, and what's unique about them, and what we can do about it. So we take a lots of different bites at that apple to try to identify what's unique about the membership and the communities we serve, and try to then localize our services around that. One prime example is we've leaned in pretty heavily into working with schools, which is somewhat of a new relationship for a lot of health plans, but the state has mandated it recently, particularly around behavioral health, trying to remove barriers for students to access behavioral health. And so there's this recent student behavioral health incentive program that I've overseen on behalf of our organization, and partnered with over 86 school districts to create behavioral health wellness programs and spaces, as well as bringing behavioral health service providers on campus, because that's where the young people are. They're captive there, and that's where we need to bring the services.
So even when you're bringing the services to the people, I mean, like, what is an acceptable level of utilization in terms of where you want it to be? Where does it land? You know, where do you hope that it would be at some point?
Yeah, that's a good question. So, we look at prevalence rates, and oftentimes you hear cited, up to one in five young people will have a significant mental health impairment during their young lifetime. And so
Yeah.
we look at prevalence rates as one thing, and then we look at our corresponding utilization rates. They're never one-to-one. So there's barriers to access, and there's also motivation for treatment, specifically in behavioral health as it relates to like substance use treatment. There's a number of folks who will get episodic services, but to go full into SUD treatment, sometimes there's a reluctance, and we try to peel back the layers of the onion to try to understand what that reluctance is. And so we look at ways to try to reduce stigma, to make it more accessible, et cetera, and so forth. But there's ongoing barriers to services at times that we just continue to try to do better, but there's always those challenges.
Well, when you mentioned around stigma, and especially, within schools, how do you kind of work around that, especially knowing that, kids, they talk, and how they say things that can be pretty mean. Are there ways to really kind of combat that, aside from continuous education, acceptance that it is okay to see, professionals? Are there other unique ways that you and the team have really kind of deployed to overcome that?
Yeah, I mean, there's lots of things happening around that. For example, some of the behavioral health wellness spaces in the schools, we've had the students themselves design them. We
Oh,
make them,
cool.
yeah, we make them student run, and then we bring the providers into that space, either virtually or actually on site. But it's really a student run milieu. There are also opportunities for students to serve as peer mentors. So it's student to student, and therefore
Nice.
it takes out some of that stigma. It's really
Right.
connecting students. So our school partners have really been at the forefront and creative around this, and I've been delighted to work with them, because I really find that they are in the best position to know the students and their families and the community, because they're from the community, they've worked with them. And so we are there to partner and support and to bring services, but they really take the lead, and it's been a fantastic partnership so far.
Yeah, interesting to just kind of note the partnering with schools. Did, was that really difficult to make that happen initially? I mean, it sounds like there's just so much red tape that you kind of have to go through. How long was that initial initiative
Yeah.
from initial conversation? I mean, are we talking
Yeah.
years here, or are you like months, or what's the?
Yeah, good question. This particular effort started in 2021, kind of the height of
Okay.
COVID.
Okay.
And schools were faced with not only the challenges of COVID, but coming back
Yeah.
into school with their students. And so it was a bit of a challenging time for that to be our first engagement with schools when they're faced with their own challenges of coming back into in-person classes. That plus a lot of schools are like, who are you? You're a health plan. What can you do for us?
Yeah.
Uh, those are legitimate questions. And, what I was able to talk to them about, a couple things is, at least in California, close to half the student population has Medi-Cal or Medicaid. So we're an important player around ensuring that their students get access to healthcare services. So that part was easy. But I think the more important part was, again, any new partnership, it starts with us listening to our schools and finding out what they need, what's important to them, not what's important to us. Let's hear
Mhm.
from you. What do you need, and what can we do to help you meet those needs? And so that was the starting point. And it was a year of us doing a needs assessment with the schools for them to identify exactly what the needs were. And then they chose their own interventions, and we supported
Mm.
along the way. So they were the driver and have been the driver throughout.
So it kind of goes back to what you mentioned earlier is true north, which is
Mhm.
the fundamental need that people want to be heard, and giving the space, the forum for these schools, for these administrators to sort of share that, and then creating a bigger circle of that and bringing in students to share what, what their desires are, and them wanting to be heard. So it's nice to see that common theme that's being drawn out um, across a much wider spectrum. So, I mean, how big is, the population that you're caring for? I mean, just give us like
Yeah.
a scope of the scale here that we're talking.
Yeah, Partnership Health Plan, we're in 24 counties. So basically anything north of Sacramento to the Oregon border, to the Pacific Ocean, to east to Nevada, we're the Medi-Cal managed care plan. And we have about 930,000 members, lives that
Okay.
we're responsible for. And about a third of them are young people. And so that's certainly an area of focus. But my focus is really on trying to ensure that we have the behavioral health services accessible for all those members who seek it out and who need it, and trying to find unique ways to remove those barriers, like our partnerships with schools, bringing more services where they're at. We also have a new effort of trying to support and fund substance use navigators in emergency rooms,
Mm,
where there's a number of individuals who may show up in an emergency room due to either an overdose or some other significant substance use event. And we don't want them just to go in there and fix the crisis of the moment, but let's actually engage them for follow-up and ongoing treatment services so that we can avoid future crises.
mm.
Um,
Are there other interesting pieces of, I mean, look, not always is a problem solved, through technology.
mhm,
You mentioned telehealth. When you are evaluating and assessing, technology, what are some of the criteria that you need to be able to like meet the member where they're at? What are some of the other areas that you guys are currently looking at that, haven't been met by a technological need that you think do need to be met by a technological need?
mhm. Well, even I'll go back to substance use navigators in emergency rooms. That there's a wonderful program funded by the state called CalBridge that
Hmm.
has started that, and now we're trying to find ways to continue this pretty effective program. But it allows for one thing that we do is we've put little tablets into emergency rooms if that particular emergency room is unwilling to begin what we call induction for like medication assisted treatment.
Hmm.
uh, we can have a provider via a tablet actually begin induction there right then, because
Wow.
it's in the moment and someone's motivated. So that's really critical technological component to the solution to get someone started on medication assisted treatment. But then concurrently, that substance use navigator, that human being that's in the
Mm,
emergency room, can connect to this individual and talk about what happens tomorrow. Who do I connect you with tomorrow? And in fact, I will take you there. And that connection, that human connection, is equally, if not more important than even that initial induction of that medication. So it's both a technological and a human connection. I've always said, and I believe strongly, that human beings grow and heal in the context of relationship. And
Yes.
that's the only way
Fact.
we do it, whether it's through parent, child,
Mm.
teacher, student, coach, player. It's mentor, mentee. It's that human connection that we grow and heal in, and that's true in healthcare.
And I'm fascinated with the approach that you're taking to that, and I think that's probably why we align so much. Is like as much as we want to talk about tech, it's really healthcare delivery is about the personal connection, the relationship, and you attempting and iterating and testing and doing that at scale. That
Mm.
is really, really interesting to know that that's being done. You mentioned something about, surveys that are being sent out to members. Are those sent out digitally? Are they sent out via paper? Just kind of knowing where people are around the spectrum. And you mentioned mostly young age folks that are, enrolled in the plan. Presumably they are using smartphones. I guess,
Mhm.
is it a lot of SMS in terms of engagement, or are there other means?
Yeah, we do it the old-fashioned way, is we mail, and that I think has its limitations, but some of it is prescriptive as far as by regulation what we have to do.
Hmm.
I think there's a lot more that can be done and should be done via phone and SMS. There are some restrictions around health plans and you know, how they can engage their members if there's not consent, and how do we obtain consent. So
Mm.
as those things get kind of weeded out, I think there will be more opportunity for different mechanisms of engagement that probably is more reflective of how individuals actually communicate. Um, a lot of us don't do things by mail anymore. So
Yeah.
it's often by phone,
Yeah.
our text. So our engagement with our members should reflect the present reality. But
Mm.
I do find sometimes our regulatory environment plays catch up, is always in the mode of catch up. So, I think we're in that arena right now where we're trying to play catch up, and also trying to, it's always a fine balance between respecting someone's privacy, but also trying to engage them to get the services that may be beneficial to them.
Right, in a meaningful way, right? It's not
Right.
it's not spamming someone and trying to just enroll them in something that doesn't necessarily help them, but having a very deep understanding of what their needs are, and meeting them through this different medium, right? Through
Right.
medium of SMS or whatever the other medium is, email. Um, what else are you really excited about? I guess if there's anything that
Yeah.
maybe we haven't sort of covered that you want to maybe take some time to kind of talk through
Yeah.
those things as well.
Well, I think if we're talking about the Medicaid program in California, you have to talk about CalAIM, the California Advancing and Innovating Medi-Cal,
Mhm.
and it's, as they say, it's a generational investment in innovation where it really has sought to kind of really change things. And CalAIM isn't one thing; it's about 3 dozen very
Mhm.
huge initiatives,
Yes.
and it it really tries to look at things broader than just health, and understanding that there are what's called the social determinants of health, and how poverty and other social or societal factors impact profoundly someone's health, and how can we actually try to move the needle on that, knowing that it will have an impact on the overall health and health costs for these
Mhm.
individuals. And so we are in the middle of implementing this statewide, and there's a new enormous initiative that comes out seemingly every other week. Uh, but it's really unique in that it allows for us, managed care plans, to contract with folks we didn't contract with in the past. Typically we contract with physicians and hospitals and health
Mhm.
networks. Now this is asking us to contract with community-based nonprofits that do housing and
Mhm.
homeless prevention work and navigation and case management. And that's one way we're trying to meet members where they're at, is these individuals who are impacted by either being unhoused or housing insecure, where they're couch
Yeah.
surfing. But
Yep.
those are important things where we can now contract with a provider to help that individual navigate towards shelter. We can even pay for housing deposits in limited situations,
Mm.
and even transitional rent in very limited ways that we can pay for. So those are meaningful. Just as an example, there's often times where there's individuals who are in hospitals that we're paying for that could be discharged if they had a safe place to go to
Mm.
recuperate. If they don't have a safe place to go to recuperate, we're paying for them to stay in the hospital at a very high rate.
Yes.
So, as an example, if we can find what's called medical respite, a place where they can go and get support and recuperate till they're well enough to be on their own, we'd much rather pay for that and avoid the more costly hospital costs. Uh,
Right.
and so we try to do that. And I think CalAIM acknowledges some of these activities, though aren't traditional healthcare costs, will actually reduce healthcare costs in the long run if we make these strategic investments. So we're embarking upon that. It is a new world for us. It's a new world for our community-based nonprofit partners, who
Hmm.
have long been saying, hey, what we do matters.
Yes.
And it's true.
It's
It
true.
does matter.
Yeah.
So these are new partnerships, and I'm excited to see where this is going to go.
Amazing. So how can sort of our community follow your work, the work of the health plan, and some of these new initiatives? Kind of maybe just sort of round out where they can get more information, more resources to some of the amazing work you guys are doing.
Yeah, well, we have a robust website that describes how any of our community partners could become contracted with us. Always open to a conversation with them. It also has on our website how individuals who want to have those services and are a member of Partnership Health Plan, they can actually request them.
Mm.
And we're certainly open to that. I think part of my goal and our role at Partnership is to remove the fear of some of our community-based nonprofit partners who have never played in our arena before.
Mm.
It's not scary. There are some regulatory hurdles, but we're here to do some hand-holding and help them through it, because they are our indispensable partners. They are embedded in the community. They are closer to our members than even we are at times. And that
Mm.
proximity to our members matters, that level of relational intimacy, so to speak. So we want to make sure that we partner with them and are good partners, and we live up to our name of partnership.
Fantastic. So for those that have tuned into this particular conversation, if you found it helpful, would you mind engaging with this content, whether it's commenting, liking, supporting it, resharing it with your community? That would be really helpful. So Mark, it's been really nice to have you come on today and just share some of the things that you've been working on, what's working, areas where you know that there's improvement. And it sounds like I'm excited to see maybe a part two of this conversation, with a lot of the innovations that you're working on and building out this network of community-based organizations, and as you mentioned, people that are entrenched in the community, and to see what other outcomes that drives, because at the end of the day it's about helping your community and meeting them where they're at. So thank you for coming on today, and I'm looking forward to future conversations.
Well, thank you, Michael, and thank you for bringing this to the fore. I think these are important conversations, so I appreciate it.
You bet.